All right. Good early morning to our early risers. We really appreciate you coming. Mark and I had a plan that if there was nobody here, I would sit in the audience while he did his part, and then we'd switch places. But anyway, we appreciate you being here early in the morning. Although, as Robert Sidonio told me on the first day, it's not early, it's 10 o'clock for me. Whereas I'm actually rarely in my own time zone, but I am today. Anyway, thanks for being here, and we'll go ahead and get started. We're going to talk about hemophilia B gene therapy. My name is Guy Young, and I'm happy to be here with Mark Redding. And we want to thank PeerView for providing this session, and CSL Behring, who provided the educational grant for this symposium. And then, yes, we're going to have some polling. So the slides, and there's also some practice aids, can be accessed in the activity menu now, and they can be downloaded after the session, so you can have all of this for you later on as well. So here's the first polling question. So select the option that best represents your current thinking on the role of gene therapy in hemophilia B. I think you guys can read the answers yourselves, and we'll give you a few seconds to answer. I was trying to guess the music. All right, so the choice of gene therapy should be individualized is the plurality of the answers. There's also some unsures. And okay, really interesting, bit of a spread across the different possibilities. Yeah, I mean, I don't think we disagree that it needs to be individualized. I guess we can get into some of that as we go through the discussion. All right, and then there's another polling question. This is about your current experience with gene therapy. So again, go ahead and, if you don't mind answering this poll. All right, let's see what we got. So there's quite a few that are not using it, and some that have not considered it, and very few who've actually personally administered it already. Okay. Go to the next poll question. This is, I think, the last one. What is the greatest challenge or unanswered question when you consider gene therapy? So one more question for you to answer. A little bit of mix, but all of the above are relevant. I think, yeah, I think that makes perfect sense as well. All right. So these are our goals for today, is to talk about the long-term evidence for hemophilia B gene therapy, discuss patient selection, which obviously was one of the questions, and to discuss how we deliver care, how we sort of manage the overall logistics of the gene therapy. So a little bit of background. I mean, this is, I think, very, to this audience, very obvious about gene therapy and hemophilia B. Hemophilia B obviously is due to factor IX deficiency. And we know about, the complications, particularly hemarthrosis is a major issue, as we all know. I think you can see the rest of the complications here as well. And so for hemophilia treatments now mostly broken down into these categories: factor replacement, and there's been a lot at this meeting discussing the pros and cons of that. There's been a lot at this meeting on the non-factor therapies, factor VIII mimetics and rebalancing agents, which have really come into the fold. And then gene therapy. Gene therapy, ultimately the aim is to be a cure, and How we define cure can be debated somewhat, but the whole point is to restore some endogenous protection of factor 8 or factor 9. Today we're talking about hemophilia B, so that the patients can essentially make their own factor the way people without hemophilia make their own factor. And we want to maintain good hemostasis, really prevent joint bleeding, and really reduce the long-term impacts and improve quality of life. And gene therapy certainly has the potential to achieve all of these goals. So with that, I'm going to pass it to Mark to talk about how he starts the conversation on gene therapy. So.
All right, good morning, and as Guy said, thanks to you guys for getting up early to come engage in this conversation with us. We're going to have some cases to talk through and try to stimulate some thoughts and conversations amongst you guys as well. So we'll just start out with these two cases here, and we're going to come back to these a couple times throughout the session today. So let's just consider these. So the first guy is David. David's 42. David has severe hemophilia B, factor 9 levels less than 1%, and he's interested in gene therapy. He's got chronic arthropathy in probably more than one joint. Given his age, he didn't start prophylaxis in early childhood, and so I would expect this guy to have at least a couple of joints that were problematic. He has a history of hepatitis C that was successfully treated, and he also has hypertension, although it's not all that well controlled. And as I mentioned, he's interested in gene therapy. The second case is Tom. Now, Tom is 27, so he's a bit younger. He has moderate hemophilia B with a factor 9 level of 2%. He doesn't have any significant comorbidities. And Tom is really interested in gene therapy. In fact, he's actually already had testing done to determine his AAV5 neutralizing antibody titer. He saw one of my colleagues and had that testing done already. So he's motivated. And so the question is, with these two kinds of patients, and I think we see patients like this in our clinic, I assume you guys do as well. So when these types of patients come in, how do we start to think about discussing gene therapy? How do you screen and assess patients to determine their eligibility? And then who all else from the team needs to be involved in that conversation? So I'll just ask Guy, what's your take on this? And I don't know if you want to start with one or the other of these guys. I can offer some comments as well.
Yeah, just briefly, I think so. My take on gene therapy is that really anybody older than 18 should be considered, eligible unless they have an inhibitor, right? Unless there's something obvious. So if you're older than 18, you have hemophilia B, and you don't have an inhibitor, I think that discussion has to happen. Then obviously you go through some of the shared decision making, sort of like, is this something you're interested in? Let's explain how it works, and you get into that discussion. And then at that point, you kind of filter out the patients who are like, no, I'm not interested. I've had patients say, no, right now I'm not interested. And so that's fine. I don't push the envelope. That's not my job to coerce them into gene therapy. And then there's others who are really interested. And then if they're really interested, then we start going through the eligibility steps, which is really not that much. It's some lab testing, including what Tom has already had, and then some diagnostic imaging, and the actual functional eligibility testing of the liver health is really not, that part's not complicated at all. I think it's really distilling who really is motivated enough to go.
Yeah, no, I agree, and I feel very similar, and it's always interesting when we ask patients, why are you interested? It's a very insightful question. You get a sense of what it is that's driving them to want to potentially pursue this. Just to get into some more maybe granular detail about these two cases. So for David, it's great that he had his Hep C treated, although I'd want to query a little bit further about other potential things that might affect his liver function. So alcohol use being a big one. And so that will come through in the screening that Guy alluded to, and we'll talk more about that in a bit. I also would be curious as to why his hypertension is not well controlled. That's for me, that's a little bit of a red flag. Is it not well controlled because he hasn't been adherent to a medication that's prescribed? Has he not been prescribed a medication? Does he not come back to clinic? There could be some potential issues there to sort through. So these are the sorts of things that can give you some clues as to the types of things that will be important for that shared decision-making conversation. For Tom, obviously he's very motivated. He's already taken one of the first steps to get the antibody testing done, and so that's great. But again, for me, it's like, okay, well, we maybe need to back the bus up a little bit. Let's make sure Tom knows really what he's getting himself into. So we've had patients that have come in extremely motivated, but when we start talking about what really is involved and what all there has to be considered, you know, we found some patients that maybe don't have quite as good of an understanding as we maybe thought they might. So may not be that way, but these are the kind of things to think about. So these initial conversations are really important, I think, because it tells you some of the things that you might need to focus on a bit more and dig into a little bit deeper. As the conversation moves forward, the next step then is to really get into some of the nitty-gritty details. So what are the expected benefits? What are the potential complications? What is this really going to look like? And so those are the important things to talk about with the patients. And in the interest of time, I think maybe we'll just move forward, because in the next segment, we're going to talk about all of these key points. So before we get there, just a quick sort of taking a step back, like there's different ways to do this. Now, we only have one potential way of doing it now, but just to make sure we're all kind of on the same page, there are a variety of technologies that we now have to essentially fix a broken gene. So we have gene editing, which I think most of us think about CRISPR. There are other platforms to accomplish that, but gene editing is essentially repairing or replacing a missing gene or a broken gene. We have cell therapy, and I think we all think about CAR T therapy as a classic example of that, and this is really a platform that has expanded very rapidly in the last decade. This is where we introduce a functional gene into cells ex vivo outside the body, and then we give those cells back to the patient. But what we're doing right now with hemophilia gene therapy is really gene transfer, so vector-mediated delivery of the functional gene into the body. So it's a little bit different than these other technologies, although we'll talk in a couple of minutes about some newer gene therapy approaches that do utilize some of these other technologies as well. So the terminology sometimes can get confusing for patients, and I think it's important for the team to have at least a basic understanding of these different types of technologies that may be used in this process. So where are we at right now? The current landscape for hemophilia B gene therapy is pretty limited. So we have etranacogene dezaparvovec, or Hemgenix, which was the first approved hemophilia gene therapy, received its FDA approval in the fall of 2022. There was another drug that also got approved, fidanacogene elaparvovec. It had the trade name of Becvez. That drug got approved in April of 2024 and then was subsequently withdrawn from the market about a year ago. Important to note that this was not due to safety or efficacy issues. It was really more of a commercial business decision on the company's part. So we're really left with just currently one hemophilia B gene therapy option. So just a little bit of an overview, a slightly more detail, and this is, we get into this in varying levels of detail with our patients depending on their interest and so forth, but this is just a cartoon that illustrates really what's happening. So we're taking the gene of interest. In this case, it's the factor IX Padua gene. This is a naturally occurring mutation that causes factor IX levels to be 6, 7, 8-fold higher than what we would consider normal. So this is taking advantage of a natural mutation. This allows us to hopefully use lower vector doses and still get good factor IX expression. So factor IX Padua is the DNA construct. This is packaged inside an AAV viral vector that is administered through a peripheral vein intravenous infusion, and then those viral vectors deliver their payload to the hepatocyte, and then the hepatocyte is able to produce the functional factor IX. So at a very simple level, this is how the process works. So let's dig into some of the detail from the HOPE-B study. So this is the phase 3 study that led to the approval of Hemgenix. So first is to talk about eligibility. So this is just a table that summarizes the demographic characteristics of the patients in the study. So you can see that this is for adults. So the age range in the study was 19 to 75. This is an approved drug for adults, so 18 plus. There's no upper age limit. They had people up to 75 in the study. In terms of severity, it's severe or moderately severe, so factor levels of 2% or less are eligible for this, although the prescribing information actually doesn't specify a specific factor level. This is for the purposes of the study, although I think a lot of the payers pay attention to that and have some thoughts about that, so we can maybe discuss that in the Q&A at the end. You'll notice from the middle part of the table that there are patients that participated in the study that had HIV, not a lot, but a few, and certainly previous viral hepatitis, not uncommon in our population. Important to note that those folks are eligible, although those viral conditions, of course, need to be under good control. Now, the question about antibodies has already come up, so the call out here is showing that. Antibodies against the vector, some of the gene therapy trials that we've seen have excluded patients that had antibodies. This one didn't. So patients that had antibodies were noted, and there were about 40% of the patients in the study that had pre-existing anti-AAV5 antibodies. They were allowed to receive the treatment regardless of that. Only one patient for whom that was a problem. It happened in one patient. So this is a patient that had a very high baseline titer, 3,200, and that patient did not express any factor IX. So that was the one patient for whom the antibodies caused a problem. All of the other participants had titers that were quite a bit lower than that, so 700 or so or less than that. So we'll have some more time to talk about that towards the end. So thinking about safety, so here's a high-level summary of the safety data from the study. And again, this is something that patients are going to want to know about when you're having these conversations. No treatment-related serious adverse events were noted, no factor IX inhibitors, no thrombotic events. There were 2 deaths of patients that participated in the study, but those were unrelated to treatment. In terms of long-lasting genotoxicity, this is a topic that's been talked about a lot over the last several years. There were 3 cases of things that might raise the question about that. There was a case of hepatocellular carcinoma, a case of a schwannoma, which is a non-malignant peripheral nerve sheath tumor, and then one individual developed myelodysplastic syndrome, MDS. But all of these have been previously reported, but all of these, importantly, were unrelated to the gene therapy treatment. And this is based on really detailed molecular analysis to tease out whether there was any connection to having received that prior gene therapy and the development of these tumors, and the answer is there was not. So again, some patients may want to get into this in a lot of detail, others may just be satisfied with an answer that nope, there's no problems. And so I think it's important for us to be aware of these things and be able to speak to them and reassure our patients if they need that information. In terms of treatment-related adverse events, you can see from the graph here, there were 100 of those, but 90% of those happened in the first 6 months. So beyond that first 6-month interval, adverse events related to the treatment itself were actually quite uncommon. And to take a little bit deeper look at that, here's the table from the paper. This is actually from the package insert as well, but it shows you what those most common adverse events were. And as you can see, it's mostly stuff that was related to the infusion itself, so infusion-related reactions, and then of course elevated liver enzymes. And you can see the percentages there of individuals that had those various side effects. Again, the majority of these are occurring in the first 6 months. There were some cases of late liver toxicity, so LFT elevations that happened beyond that first 6 months window. Important to note that most of these were quite mild, actually, so less than 2 times the upper limit of normal, so very, very minor bumps in the liver enzymes, and those resolved without any additional immunosuppressive therapy. So the need for corticosteroids to manage liver enzyme elevations is really something that's happening right up front in the first few months after receiving therapy, and beyond that, these issues don't seem to need additional treatment. So again, these are the levels of details that some patients are going to need to know. Others may not need all of the information, but important for us to have that information, be able to speak to it as we're counseling patients. So let's think about efficacy. So I think this slide, or this graph is from the most recent publication. Steve Pipe presented this at ASH just a couple of months ago, 3 months ago, I guess now. So this is the 5-year data from the HOPE-B study. It shows the factor IX levels, and you can see from the graph 2 things, I think. So the first thing is that they're stable over time. So at 6 months, the mean factor IX activity was 39%, and at 5 years, it's 36%. So durability really seems to be there over an extended period of time in this cohort of patients. So I think that's the first important takeaway. The second thing is you'll notice there's a range, right? So although the average factor IX level is decent, quite good for most people, there is a range. There are people that have frankly normal levels, and there are individuals that receive this treatment that won't have levels that are in the normal range or even close to 30%. And so I think it's really important that patients understand this. Right now, we don't have a clear understanding of why there's so much variability from patient to patient, and we do not have the ability to predict how an individual is going to respond to any gene therapy treatment right now. So these remain really important points for patients to understand, and making sure that we're setting expectations. So it's great to focus on the positives of this, but I think it's also important to sort of be fair balanced in the conversation with the patient about realistically, we don't know how it's going to go for you, and the patient has to be prepared for the potential that they may have a response that's maybe less than they had hoped for. And of course, it's always possible it could be better than they were hoped for as well. So really important to talk through this, and I think the durability question is certainly one that comes up. We know with factor VIII gene therapy, durability has been a big concern. We don't seem to have that issue with factor IX, fortunately. So taking a look at some other efficacy data, of course, one of the questions that we're going to be very focused on is what about bleeds? So it's great, you can get gene therapy, you can get a factor level that's durable over time, but what does it translate into clinically with the thing that we're really trying to stop, which is bleeding? And so these data show you the bleeds broken down by different categories. They looked at the lead-in period, so that was the several-month period before receiving gene therapy, collecting data on patients' baseline bleeding frequency on the treatment they were on prior to getting gene therapy, and then looking at their bleed rates after receiving gene therapy. And you can see from the graph that there's really significant reduction here in bleeds, depending on how you break it down. So all bleeds, spontaneous bleeds, joint bleeds, and traumatic joint bleeds, regardless of how you slice it, really significant improvements. So 63% reduction overall in bleeds. Another way to look at this is factor usage. So how many patients are able to come off prophylaxis and stay off prophylaxis? I think this is an important point, and the details are here. I think a lot of this has been talked about already at other conferences, but just to make sure to talk through it in a bit more detail. So 94% of the participants were able to discontinue their prophylaxis and stay off of it. That's 51 out of 54 patients. So what about the 3 patients that weren't? Well, 2 of them are listed in this first sub-bullet point. So there are 2 patients that stayed on prophylaxis from the get-go. One of those patients only received about 10% of the intended dose, and this was due to an infusion reaction. The infusion was stopped and not restarted. This was early on in the clinical trial experience, and so that individual only received about 10% of the intended dose, and as a consequence didn't have any expression. The second individual I already mentioned, this was the person that had the very high baseline neutralizing antibody titer, and that individual also did not express any factor IX. So if we exclude those 2 patients, what about the patients that actually got the gene therapy? How did they do? Well, there was really only 1 patient who had a factor IX level that dropped low enough over time that they needed to restart prophylaxis. This individual did well, but at month 29, the factor IX level had decreased to a point that the bleeding frequency was starting to return, and this individual did go back on prophylaxis. So overall, I think these are very good and very impressive numbers, but again, it's important for patients to understand how things happen, and so it's important for us in our teams to be able to speak to these points in the level of detail that our patients need. So just to give you a quick look at what else is out there. So we've talked about the current treatment landscape with gene therapy, hemophilia B. There are a couple of things that are coming. So the first here is the Regeneron product. You've probably heard of this. This is a dual vector system using AAV8 to deliver the factor IX gene. This is the wild type factor IX gene, not factor IX Padua. In addition, there's a lipid nanoparticle delivery system for the gene editing package, which consists of a guide RNA and a CRISPR-Cas9 system. So this is an example of in vivo gene editing happening in the patient. Hepatocytes are the target, of course. The study is called Beyond 9. The goal is to treat both adults and children, starting with adults. I know this study is open, and I think some patients have been dosed already. I don't have any other details, and certainly don't have any data yet to share, but that's an exciting one that we're paying attention to. The other one is the one from B Biopharma, BE101. This is a little bit different platform. This is an autologous B-cell medicine platform. How this one works is we use peripheral blood leukapheresis, and we remove white blood cells and extract the B cells. The B cells are then subjected to gene engineering ex vivo with a similar system, so using a CRISPR-Cas9 to open up and to insert the factor IX Padua gene. It's the same cassette that's in Hemgenix, actually. These B cells then are cultured in the lab and expanded and differentiated into long-lived plasma cells. And those are the cells that produce the factor IX. Those are the cells that are delivered back to the patient. The first patient, this is called the Become-9 study, the first patient was dosed in July of 2025, actually at our center. We've dosed a second patient as well, and I think more to come. So we don't have data for either of these yet, but this is just an example of the platforms that are still being investigated, and whether these things will overcome some of the potential limitations of the current platform we have or not remains to be seen, but certainly worth being familiar with. And again, this might come up in conversation with patients. If the patient asks what else is out there, I think it's important for us to be able to at least speak to a certain degree about what the landscape might look like. Okay, so with that background, we've talked about efficacy, we talked about safety. So where are we at in the conversation? So I want you to kind of reflect back on this. And the question is, how do you think these data support a role for gene therapy in patient care? So we'll give you just a minute to consider that answer, and we'll see what you say. Okay, so a little bit of a spread, but I think the majority of us are feeling that, yeah, the evidence showing durable factor IX levels and bleeding reductions is convincing. Some people still needing to see a little more data, and I think that's fair. A couple people maybe still a little bit needing some clarification on this. So I think this is what I would expect the answers to be. So I think more and more of us are getting more comfortable with the data, but it really, I think, speaks to the importance of getting the data out there, letting us think about it, noodle it, talk about it, so we can understand it in detail. Because again, we have to present this to our patients and their families as we're having these conversations. So in terms of the screening, we touched on this, and Guy and I, as we went through kind of the analysis of the cases, we touched on these topics, but I want to really just hit these again to emphasize some points. So in terms of screening and assessing eligibility for a patient's suitability for receiving hemophilia B gene therapy, these are the high points. So the first is the antibodies. We talked about these already. AAV5 is the delivery system. Pre-existing neutralizing antibodies do exist, but they do not preclude treatment with Hemgenix. These antibodies are generally present in low enough titers that it doesn't seem to make a difference. Now, in the package insert, this is not a requirement to have this testing done. The patients are encouraged to participate in an ongoing study looking at baseline antibody titers and how that influences outcome, but it's not a requirement per the prescribing information, although again, I think our payers are going to want to see this. At least in our area, the payers are focused on this. So that testing, I would expect it to be done for most patients prior to receiving the gene therapy. Factor IX inhibitors is another one that's a little bit interesting. You know, in the clinical trial, patients with inhibitors were not included, and certainly an active factor IX inhibitor would be a contraindication to gene therapy. But the question that sometimes comes up is, what about a previous history of factor IX inhibitor? Of course, we don't have a lot of those patients. Factor IX inhibitors, fortunately, are pretty rare, but there may be somebody who had a previous inhibitor years ago, and perhaps either they got tolerized or maybe it was a transient inhibitor. And so the question might come up, how does that impact their suitability for gene therapy? Again, we don't have data from the clinical trial experience about those types of individuals, but this is not a contraindication per the labeling indication. Again, I think payers might have thoughts about that, so it's important for us to be able to speak to that as well. Liver health we've talked about. Not in a lot of detail, but we've touched on this. You know, this is actually probably a big topic of conversation if you think about all of the things that a patient might come into this conversation with. Understanding the status of their liver health is really important. So, of course, in our population, we think about viral hepatitis, but alcohol, metabolic liver disease, these are all things that I think are much more prevalent than we might have previously thought. And so really important to understand patients' baseline liver health and assess that prior to considering gene therapy. So the assessment is fairly straightforward. I mean, obviously basic liver enzyme tests, but beyond that, imaging with ultrasound and elastography to assess for degree of liver fibrosis are important baseline assessments that need to be done. And then the last thing is immunosuppression. So if liver enzyme elevations do occur, the treatment is corticosteroids. And so it's important to think about would this individual that's considering gene therapy be a reasonable candidate for corticosteroids? The doses are relatively high, and it goes on for a few weeks. And so important to think about, does this individual have some baseline comorbid conditions that might make them less well suited for that? So diabetes, for example, or as in the case of our first patient, David, hypertension. So treatment with corticosteroids could potentially worsen those underlying conditions, and so important to know that those folks are going to need closer monitoring. I wouldn't say this is a contraindication, but something to be aware of, and something to make sure that we talk to the patient about, that this might require some additional monitoring to make sure that the immunosuppression doesn't exacerbate those pre-existing conditions. So those are the highlights to think about, and these are the things that happen in the conversation. This is a very detailed slide. I'm not going to speak in detail about it, other than to just sort of say this is the menu of all the stuff that we have to talk about. We've covered all these things, and again, the level of detail that an individual patient might need is going to vary depending on how much information they come into the conversation with. But to hit the high points here, I think important to understand expectations, setting expectations, understanding why the patient is interested in gene therapy, what do they know about gene therapy, what is their understanding of what this journey looks like. It's way more complicated than just getting an infusion. There's the stuff we have to do ahead of time to make sure they're a good candidate. And then I think the biggest part of it is actually what happens afterwards. So the monitoring, how frequent, for how long, and that's really important for people to understand. It's weekly lab monitoring for 3 months to make sure those liver enzymes are attended to. What's the process that's going to be set up to make that happen? Where's the lab going to get done? Who's going to get the result? Who's going to act on it, and so forth. So mapping all that out, making sure the patient understands what they're getting into is really, really important. We talked about efficacy and safety. Again, some patients are going to want a lot of granular detail, others may not, but we need to be prepared to be able to communicate that stuff if needed. And then a couple of things over on the right-hand side that we haven't talked much about, but just to touch on it now, some lifestyle modifications. So alcohol abstinence, there aren't firm recommendations, but certainly, this is therapy directed towards the liver. So obviously, you want to do anything you can to keep your liver happy. And excessive alcohol use is certainly one of the things that makes your liver a bit unhappy. And so it's really important to talk to patients about that. We don't have great data about what amount of alcohol might be problematic, and so I think most of us are saying, you should really abstain. It's certainly in those first few months when the gene therapy is being delivered. Beyond that, I think we have to recommend moderation, certainly. We don't have granular detail about how much is tolerable, but I think it's really important to have that conversation with patients. Donation restrictions, we didn't talk about this, but there are details in the package insert about viral shedding, vector shedding in body fluids, and we know that the majority of patients will continue to shed for at least a couple of years. What that really means in terms of potentially donating blood or tissues or organs is a little unclear, but the recommendation is to not do it. And so again, I think this is an important point to at least make sure patients have heard. So this conversation is not a conversation. This is a series of conversations. This isn't something you can do in a 30-minute clinic visit. This is really a conversation that needs to be ongoing over several visits. Some of those could be virtual, but it's really important to take the time to do this. Again, there may be other people on the team that need to get involved in this. The social worker is a key person, sometimes a nurse coordinator, someone who knows the patient really well. You need to consult with the hepatologist if there's concerns about liver function and so forth. So I think it's important before we get into this to know that you have to commit the time to have all these conversations and make sure that everyone's on the same page and that expectations are aligned before moving forward. All right, with that, let's return to the cases. So remember the first case was David. This is a question about Tom. So Tom was a 27-year-old with moderate hemophilia B, 2%. With really no comorbidities, but he's very, very eager. So he's already had his neutralizing antibody titer assessed at 600, and he really wants to move forward. Based on the information we know about Tom, how would you view his eligibility or candidacy for gene therapy? All right, so Interesting, yeah. So about half of you are answering that Tom is likely an appropriate candidate pending passing the standard eligibility evaluation. The question about the neutralizing antibody titers, again, his titer is not prohibitive. He is able to receive gene therapy even though he has some baseline antibodies. The factor IX level, so he's 2% in the clinical trial. 2% or less was allowed in. The label doesn't speak about a specific factor IX level. It talks about a bleeding phenotype. And again, I think payers may have different thoughts about that. We've tried really hard to work with the payers in our area to help them understand that bleeding phenotype should be the criteria rather than specific factor level. Of course, a factor level was used in the clinical trials because that's how we have to do clinical trials, but in the real world, it might be a bit different. And then some of you are still needing some more information. I think that's fair too. So very good. This is, I think you guys are getting it, and I think the key point really is to be prepared to have that series of conversations. As we move forward here, this is a place where we can break. So before we move forward further, are there any questions that have come up? Anything that we've talked about that's piqued a question from anybody? Hang on, there's a mic coming for you.
Yeah. Yeah, so the GLP-1 therapies which are used for diabetes now, any data on those?
Yeah,
Because a lot of people are going to be on
Yeah, that's a
that.
great question, actually.
So one question, and the second question is, we are seeing non-alcoholic steatosis of the liver. So I'm a pediatrician, so I hope the terminology is right. But is there a problem with that, with the GLP?
Yeah, so both very good questions. So the GLP-1 inhibitors, the short answer is no data that I'm aware of. You know, they have become available very recently, and I don't think anybody that was in the clinical trial probably was using those drugs. They weren't around when the clinical trial started. So that's an important question and something we would need to be paying attention to. But there's no data that I'm aware of in that regard. Pardon me? Preclinical data, yeah, not that I'm aware of. The question about metabolic liver disease, or whatever the current term is, and you're right, the term keeps changing. It's common. It's much more common than I think we used to think it was. The degree to which it can impair liver function and cause fibrosis varies quite a bit, and I think it has a lot to do with what other things may be going on, particularly alcohol. So that would get picked up as part of the screening. You know, we would recommend doing elastography or assessing for fibrosis in the liver as part of the baseline evaluation. So I think we would love to have more granular, detailed data about what amount of liver fibrosis and from what cause might cause a problem. We don't really have that. People were not allowed in the study if they had, you know, significant hepatic impairment, but like, what does that really mean in the real world? I think that's what we all have questions about. This is why I think it's very important, as part of the conversation with the patient about eligibility and what this is going to look like, the commitment to long-term follow-up as well, because there are still questions that we need to learn the answers to that we couldn't learn in the clinical trial, but we're going to hopefully learn in our real-world experience. And the only way we're going to understand that is to be able to keep tracking patients and following them long-term. So I think that's an important part of the conversation as well, is to encourage patients to be committed to that long-term follow-up so we can answer questions like this. Yeah. Okay, I think we got to move on.
Yeah. All right, so being conscious of the time that we have, I have just a few slides and talking about the multidisciplinary team, and I won't I will not reiterate a lot of the points that have been made. So I think just because we're a bit over on time, that Mark and I won't have this discussion currently. We could do it after, about what are the steps sort of within the institution. So there's an institutional journey, and then there's also the patient journey. And those are things that need to be considered. So just a couple slides from me. So this is the patient journey. Obviously, we've discussed a lot of this. This comes from a publication that there's one listed there, and there's another publication as well that talks about this. So we say day minus 80. I mean, it's a little bit obviously flexible there. You don't have to wait 6 months from starting the discussion with patients to getting to the point. But it's kind of just to make the point, like, start the discussions early with patients. That's why I really do believe any patient, Hem B, older than 18 who doesn't have an inhibitor, you should have that discussion. They may not end up getting gene therapy. They may not end up being eligible for gene therapy, but you should have the discussion. And because, as Mark said, it's a series of discussions. And I usually have the discussion, and then we see the patient back in 2 months or 3 months or 6 months, and then go to the next step. So it's really, I'm not going to read all the points under there in terms of the pre-infusion steps, but once a patient says to you, yeah, I mean, for me, even if they say, I think I might be interested, that's enough for me to say, well, let's just do the labs, and then you're going to do an ultrasound and a liver fibrosis scan. Now, an ultrasound is not technically required, but just a little sidebar. So I had a patient, I insist on getting an abdominal ultrasound. The FibroScan or the liver fibrosis scan, that is required. That the payers absolutely will not approve it. So I had a patient who was eligible. I said, no, I still want to get the structural ultrasound. And he had a small little lesion in his liver. It just turned out as probably a hemangioma. We didn't even have to do anything about it. But imagine what would have happened if I didn't do that. I gave him the gene therapy, and then 6 months later, I had right upper quadrant pain, and I did an ultrasound, and I saw a lesion in his liver. I'd be freaking out. Oh my God, the gene therapy. So I think getting a baseline liver ultrasound makes sense, because a lot of people have little hemangiomas or little things in the liver. So that's why I kind of think that doing that is helpful. It's not a requirement. The payers don't often necessarily require it. Then as you get close to the infusion, you just want to reconfirm with the patient, like, yes, I want to proceed. This is an important step before you actually order the drug to you. There's a procurement process with ordering the drug, which we won't get into, but you want to, 2 weeks before, it's like, okay, you're in, right? You're definitely in, right? You want to do this. Yeah, I'm all for it. And that's when you'll start the process of procuring the product. And then obviously the dosing, you admit them to the infusion center. It should all be a one-day process. Mark mentioned the patient only got a 10% infusion. It was early on in the trial. I mean, that was a mistake, admittedly, and it wasn't my mistake, but it was. we won't say which center it was, but and it doesn't really matter. It was the patient had an infusion reaction. It wasn't sure what to do. They admitted him to the hospital, and then the hospital didn't have the infusion. And so, but the point here is, if there's an infusion reaction, there are ways of dealing with it. The first thing is slow the infusion rate down. If it's not resolving, you can just give some very simple medications. I had a patient who did have an infusion reaction. We actually stopped his infusion. Within 15 minutes, he was basically fine. We gave him some Tylenol and Benadryl, very simple medications. We resumed the infusion at like 10% of the rate. We built it up to 25% of the rate, then 50% of the rate. We actually looked at the time, we're like, he's going to be done by like 3 o'clock. Why push our luck? So we just kept it at 50% of the rate. Instead of being done with the infusion at 1 o'clock, he was done at 3 o'clock. Instead of going home at 4 o'clock, he went home at 7 o'clock. So it really wasn't all that big a deal. So yeah, infusion reactions happened in like 16% of the patients, so they will happen. And then the short and long-term follow-up, I think Mark already mentioned, weekly laboratory testing for 12 weeks. And then after that, it's kind of at your discretion how often you'll be checking after that. I'll typically go to every other week for a couple of weeks, and then after that we'll go to monthly, and then, I mean, if they've had no ALT or AST rises, I pretty much will stop checking ALT or ASTs, because kind of what's the point at that point? You're not going to institute steroids at month 6, 7, or 8. If there's a later ALT or AST rise, it's probably something else. It's probably in somebody who's like abstained from alcohol because they've been really good about it, but went to celebrate something with their family or whatever and had a glass of wine or two, and maybe that's what tipped them over. The lifestyle restrictions we've been discussing, and then after that we just kind of follow the patients in a regular schedule. It could be biannual, it could be annual. I think it depends on your center. So this is the multidisciplinary team. This is what you need to build in order to provide really a proper overall delivery of the gene therapy. Obviously, there's a hematologist involved, but you need the pharmacy, because unless you, the hematologist, or your nurse is going to mix this product, no, you're not going to do that. Just so you know, the product comes in many small vials. So an adult patient, you'll get delivered, depending on their weight, 30, 35, 40 little vials, and then those have to each be opened up, and they have to be mixed in a bag of saline. I mean, yeah, you need a pharmacist to do this. The pharmacist will get trained on how to do this. It's for pharmacists, it's not that complicated, but it is a bit time-consuming. This particular product comes in ambient temperature, so there isn't any thawing involved. The hemophilia A gene therapy comes frozen -80, so that's got even yet another step, but I guess we won't have to be dealing with that anymore, unfortunately. Hepatologist, I think, that's optional. I think if you have a patient with some liver issues that you are actually still considering giving the gene therapy, you could consider getting a hepatologist involved to help you navigate that. Psychologist is optional. We happen to have a psychologist on our team, mostly for me, but also for the patients. But yeah, we might have her get involved to just, navigate some questions with the patient. Not that the patients have to have, psychological issues, but just understanding that this is a very significant change, like you're in how we manage the hemophilia and things like that. Nurse coordinator, I mean, that's super critical. Aren't my nurse coordinators, if it wasn't for them, I don't know how we'd organize all the post-testing. I mean, they help with the pre-testing, but it's the post-testing. The patient needs to have a plan for the post-testing. It's not like you do the infusion and then you're like, okay, let's see, which lab is he going to? That has to be arranged ahead of time. Which lab they're going to, how are you gonna get the results, how the results will get reported to the nurse and then to the medical decision makers, whether it's you or somebody else on your team. Because if there is an ALT or AST rise, you need to start the prednisone or prednisolone, the steroids, essentially right away. And so for that reason, we also prescribe prednisone to the patients to have at home. I mean, you're delivering a multi-million-dollar drug. Having $10 worth of prednisone in the house, because literally that's like what it costs. If they don't need it, yeah, that's fine. You can throw it out, or they can give it to their dog, or whatever they want to do. But so we prescribe the steroids ahead of time. They have it at home. So this way, if they get the call, hey, your ALT went up, I need you to start the steroids, it's not scrambling for which pharmacy and, oh, I'm too busy to go to the I'm out of town this week, can I start it next week? No, I mean, they have to have the steroids with them. So we make that point very, very clear. And then obviously the infusion center, you're gonna have to work with them because this has to be delivered in the infusion center. I had to do a gene therapy little talk to the infusion center nurses before they agree to be part of this, which I think is fair. They want to know what they're dealing with, and so yeah, you have to sort of build this structure. Yeah, I already talked about the infusion reactions. We already talked about the liver enzymes. I mean, risk for thrombosis. There haven't been any events with this product. There have been events with other products where factor levels go super high. I mean, if you have a patient who ends up with a 250% factor IX level, which is extremely, extremely unlikely, yeah, then I guess just be prepared for thinking about how you might handle that. But I think that's extremely unlikely to happen. So back to our patients, the two patients were counseled on all of these issues and what to expect during and after the infusion. Yeah, you don't need to tell patients what's going to happen on infusion day, which is mostly they're going to be sitting around having people hanging around them, putting an IV in, et cetera. I'll tell you a funny story. When one of our first patients was probably like 7 years ago because he was on the clinical trial. So I was there like in the infusion center, just making sure everything would go okay. And when the infusion ended, I went to his room. I said, yeah, so the infusion's over. And he looked up to me. He's like, well, that was anticlimactic. I was like, yeah, that's what we wanted it to be. He goes, I don't know. I thought there'd be like something else about it. Like, no. He's like, it's just an IV infusion like factor. It just took longer. So yeah, I mean, the infusion, I usually tell everybody, the infusion itself, that's actually pretty much the easiest part of all of this. That's very straightforward. Unless there's an infusion reaction, then there's some things to be done about it. For Tom, obviously discussing his AAV5 antibody results, explaining that it's unlikely to affect the long-term impacts. So yeah, I think these are the main points. I think I've already gone over these. I want to definitely save some time for the Q&A and further discussion. So one more poll question here. So how prepared are you with your multidisciplinary team for gene therapy and for the long-term care? So if you guys can answer that question. All right, let's have a look. Oh, that's great. I mean, yeah. So 3/4 are prepared. So that's really fantastic to see that, because we know that that's been a bit of an impediment to getting this going. So like, for example, for me, to make a very, very long story short, it took me a year. It took me the entire, so the drug was approved in 22. It took me all of 2023 going through multiple committees in my hospital to get them to agree to allow us to do this. I won't go through all the committees. So, I mean, there is quite a lot of effort. It depends on your institution. I think I always say this when I get to this part. I say kudos to the center in Green Bay, which was the first one to dose a patient. I remember somebody's like, Green Bay. And I'm like, yeah, what? They're like, I can't believe it wasn't like one of the big institutions. I was like, no, I actually can believe it wasn't the big institutions because I work in a big institution and I know the bureaucracy. So that was, there's HTCs that are, smaller, nimbler operations. They're more private practice kind of things. They're not in a big institution. And so they don't have the same level of bureaucracy. They still have to have all the teams. They still have to go through the process, but they're able to do it, more quickly. So I'm glad to see that many people are prepared. So we can go to I think we're getting close to the end. We want to definitely save some time for questions. So here we are in the Q&A part, and I'll have a seat so that I'm not standing over Mark while we do this last bit. And yeah, if you have questions, I guess you can raise your hand, and otherwise we've got questions in the iPad, and yeah, go ahead, Mark.
So yeah, I'll just take one of the questions that's come in here. I have patients who technically qualify, but I'm not fully convinced they'll follow through with monitoring. How strict are you about that? Real strict. I mean, I think this is the key thing. If they're not going to follow through with the monitoring, I think this is a really bad idea. And just to be blunt about it, the answer isn't no, you can't do it. The answer is how can we figure out a way to make this doable for you, I think. So it's important. But that is, I think, a pretty firm line for a whole bunch of reasons, as we already talked about.
Yeah, no, I mean, I totally agree. And I think one of the points I've heard in the community is like, well, my patient's not really adherent with his factors, so I don't think I want to give him gene therapy. And I really want to stress the point that adherence to factor therapy, which is an IV infusion, typically every week with hemophilia B. And I think the worst part about it for patients is like, there's no end. So you got like a 20-year-old or a 25-year-old, and they're like, I have to do this the rest of my life. I mean, it's a difficult concept, and that's where I think we see a lot of the non-adherence. I do not at all couple non-adherence to giving factor to the fact that, oh, they won't go to the lab. And yeah, we hammer that point home. You have to go. If you're not going to go, let's just not even bother with the gene therapy. So I think that's really a very, very a key point. Patients hear one-time treatment and think cure. So what language do you use to describe? So, okay, this word cure, and I know there's been a couple of papers thrown out there about, like, what does that mean? I mean, I'm going to be a purist about it, and to me, cure means your factor level's in the normal range, and it'll be there for the rest of your life. That's obviously being very restrictive about what the term cure is. Now, of course, I'm not going to be able to tell somebody that'll be for the rest of their life because, the longest data we have on this approach of gene therapy, not Hemgenix per se, but for this AAV-delivered gene therapy is about 15 years now. But we do see durability out to 15 years with the earlier versions of AAV. So, I mean, I do have confidence that this is at least a 10, 15, 20-year solution, and it could be a lot longer. I think, to tell a patient who's 20 that, yeah, this is going to last until you're 70, you can't say that. We don't know. So they're going to have to take, some, not risk per se, but some understanding that this may not be lifelong. But I tell them, look, if this lasts 20 years, I said, ask me how I was treating my hemophilia B patients 20 years ago and how far we've come. And technology is only going faster and faster. So I said, if you lose your response in 20 years, I have essentially no doubt that we'll have some other fantastic treatment for you. And worst case scenario, you can go back to factor, it'll still be around, or there's other drugs too. So I think that's kind of how I would approach that. So, I mean, different people might, I don't know, I mean, how do you think about this word cure?
Yeah, I was going to say, so one anecdote. So we had a guy very eager to get gene therapy because he wanted to be cured, and I asked him, what he thought that meant, and I thought we were going to have the conversation you just described. And actually what he said to me is they were thinking about starting a family, and he's like, I don't want to pass this on to my kids. So we had to have that conversation. So it's really important to, when a patient says cure, what does that mean to you? And I was not prepared for the answer he gave me, but I'm really glad I had that experience because it opened my eyes to the concept of, language and terminology and making sure we're understanding what the patient's understanding is. And so I haven't had that happen since then, but it was a good lesson for me.
All right, so almost 8. There's a bunch of questions that just came in, so let's try to do them like rapid fire.
Gotcha.
So during your initial conversation with the patient and you hear they may not be interested in gene therapy, do you still provide information to ensure they're truly informed?
Yes.
Okay. One says, Mark, I noticed you said if the patient asks what else is out there, do you wait for the patient to ask the question, or do you proactively provide all options and alternative therapies?
Yeah, well, right now, the only one that's out there commercially available is the one we've been talking about. We do talk, this is kind of the corollary to the first question about, we talk about all options that are available, both commercially available and clinical trial options with our patients. We take the time to make sure they know what the landscape of what's available. I think that's really important for them to know, even if I think they don't need to change and they don't want to change from what they're currently doing. It's important to provide that information. I want them to know that we are willing to have those conversations. I want them to understand that they can come to us if they have questions, because there's lots of places patients can get information, and we want to make sure that they know that we're one of those places. So we have broad conversations with everybody. Yeah.
I know we're a little over. We'll do a few more minutes, and then I know we need to go on to the rest of the meeting. How are you handling scenarios where a patient may be a clear candidate for gene therapy and is motivated, but has certain behaviors like alcohol consumption, steatosis, that would complicate the decision to proceed?
Tread carefully. Yeah, I mean, try to understand what the real those behaviors are. We have a wonderful social worker. We're very lucky pulling those members from your team in that might know the patient in different ways, or maybe know them longer than I do, to try to see if you can change some of those behaviors to make them a better candidate for this. I think is important. Again, this isn't a one-time conversation. This is an ongoing conversation. It might take some people months or even years to get to the point of being ready to actually do gene therapy, and that's okay. We need to support them through that process and be prepared to go along on that journey with them.
I'll take this one quickly. Why isn't the lab included in the multidisciplinary team? It can be. To be honest, a lot of our patients don't live that close to our center necessarily. So, I mean, we're talking about ALT, AST. I mean, it's the same machine pretty much everywhere. So we let patients get labs close to their home. For selected patients, CSL actually provides mobile phlebotomy. They'll send somebody to the house to draw the lab, so it makes it even easier. So, but I think, yeah, it's not unreasonable to, if you're going to do the labs in your place. What about referrals? There was a question about if there's a patient who's interested, but how do you handle sort of the referral situation? I mean, I've dosed a Hem A patient who lives in Oklahoma, which I know your geography. That's not close to California. We're about to dose a patient Hem B from Arizona. So, I mean, we're happy to take referrals. We know how to do the infusion. I think the key thing about that is really good communication. And then the main thing is, so in this case, the referral sites, they actually did all the pre-testing. There's no need to fly to California to get a FibroScan, or the labs for that matter. The key thing is the post-infusion monitoring, make sure that's in place, and then who's going to make the decision. In some cases, there may be an expert center. They just can't do the infusion in their center. They're like, I can handle the post-infusion. I know what to do. Then I say, that's fine. I'm available. If you have questions, just give me a call. And then there's other, like the one in Oklahoma, we're making all the decisions. We get the labs and we're making the decisions on the steroids and things like that. Yeah, we're just about out of time. So there, somebody asked about the hub and spoke model. I mean, we don't have a hub and spoke model in the US. They do have that in Europe, but again, there are centers that are, I mean, if you're interested in knowing which centers are available to infuse, it's actually on the Hemgenix website, has a list of centers, so you feel free to do that. And maybe we'll do one more here.
Find an easy one.
All right, let's see. Well, here's an easy one. If your patient otherwise qualifies but is taking resmetirom for MASH for F2 fibrosis, do you stop the conversation or continue?
Ooh, I call my hepatology friend, I think.
Yeah, see, that's where the hepatologist probably comes into play. I think that's a good one. And then, okay, we'll make this the last question. So if a patient asks about like future gene therapies, like, okay, this one looks pretty good, but maybe there's something better in the future, what do you tell them, Mark?
Yeah, I think, one of the things that we're fortunate in our community is we have a lot of really good treatments. So this is not, the decision to do gene therapy now is not something that people need to rush into. If they're not sure they want to do it and they're thinking there might be something better down the road, I think it's perfectly fine to wait. But it doesn't mean we can't have the conversation now. It doesn't mean we can't do the education. If someone's thinking about gene therapy but maybe further down the road, then I spend time talking about what can you do to keep your liver healthy so that you're a good candidate down the road. So I think there's an awful lot of things we can talk about And we try not to sort of force people into it. You know, we try to let them come to us ready, and then we walk them through the process. So there are a lot of new things coming. Whether they'll be here or not remains to be seen, but if a patient's interested in that and maybe not quite ready now, I think that's perfectly fine, and we still support them through that process.
Although, the one thing I will say, though, is that the 2 Heme B gene therapy trials that Mark showed, they've each enrolled 2 patients in the phase 1. So, I mean, best case
gonna be a
scenario
while.
is it's probably 7 years before either one of these crosses the finish line and becomes available. That's
Yeah.
if they make it. So I think that if somebody's deciding, like, I'm going to wait for the next gene therapy, if they're, you know, unless they're interested in a clinical trial, they're going to be waiting a long time. I mean, and I say, like, really probably at least 7 years. I can't imagine any of these who's, like I said, 2 patients in phase 1 trial. I don't see how the process is going to get to approval really faster than that. So that's one of the things to consider, is if they want to wait, just set the expectation that, you know, they're going to be waiting for a while. That's not meant to coerce them to get Hemgenix, it's just meant to just inform them. Anyway, thank you. I know we're a bit over time. We appreciate that you all came so early, and hopefully you got something good out of it. And thanks, Mark, for a great job.
Yeah,
And
likewise.
Thank you,
Thanks, you guys.
everybody else. Yeah.